our invited speaker, who's Dr. Farzad? Dr. Farzad.
Yeah, it's Professor Puru Said.
Okay. Okay, there are three topics he sent.
Yeah, I sent you the topics that he proposed.
And we are going to have two sessions mainly, or 3 sessions.
We can hopefully read of this coming 2 days, maybe, and this week.
We are live now, sir.
We can Farzad, we can meet together and prepare. Okay. So let us just go for today meeting.
Fine.
Okay, can you start recording? Are we live?
We are live, sir.
Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. I would like to welcome all of you, dear colleagues and friends, to Oculoplastic Modules. Today is episode 4. It will be about blepharoplasty. And before that, we have our first part. It will be, before we go to the first part, okay, can you go a little bit down? I want to introduce Dr. Mahmoud Al-Salem. He is a professor of ophthalmology, consultant ophthalmic surgeon, Al-Salem Eye Clinic, Jordan, oculoplastic surgeon, and he is behind all this work preparation for the modules. Thank you, Dr. Mahmoud. For the first part, and he's going to be the moderator of the second part. First part, it will be retinal disease. This is only a very short. It will be talking about retinal disease in focus. It will be presented by my dear friends, Dr. Mandeep Lamba. He is a specialist ophthalmologist, retinal surgeon, head of retinal service in Prime Healthcare. And he will give a talk about retinal disease in focus. In part 2, we are today honored to have a very eminent speaker in oculoplasty from different parts of the world. My dear friend, Dr. Farzad Bakdel, Associate Professor of Ophthalmology. He's Farabi Hospital, Tehran University of Medical Science, Iran. My dear friend, Dr. Mahdi Fandari, nice to meet you and have you also with us, Vice President of MEOM, consultant of Tawfiq Hospital Group. He's a consultant ophthalmic oculoplastic surgeon. Well-known figure in oculoplasty, Dr. Naresh Gucci. He's a consultant oculoplastic surgeon, practice in London, UK, consultant at the Shields and Westminster Hospital NH Trust, founder, member, and ex-president of the British Ophthalmic Plastic Surgery Society, founder and current chair of WSO PRAS. Also, we are great to have also Dr. Qasim Jamil Nasser. He's a consultant oculoplastic surgeon, Jordan Center, Amman, Jordan. So we'll start first with our first part with Dr. Mandeep, and the floor for you, Dr. Mandeep.
Thank you, Dr. Amri, for the elaborate introduction. Very good evening, ladies and gentlemen. From the onset, I would like to thank the MEOM meeting, the chairman, Dr. Amri, his colleagues for putting this effort in. Our sponsor is Bayer, Lima, Albert, if you are around. Thanks for giving us this platform to share our thoughts. It's a quick presentation basically on diabetic macular edema. And what I intend to do is present 5 back-to-back cases, 3 usual ones, 2 usual ones, and 3 unusual ones. So, I mean, all of us have come across diabetic macular edema, whether you practice retina or you don't practice retina, it's always, the prevalence is increasing day by day. And our methods of management of diabetic macular is pretty monotonous. It's just that the retina physician generally chooses one molecule, which is anti-VEGF, to start treating it with, start injecting on a regular basis, on regular intervals rather, till they get a desirable response. And if they don't get a desirable response, you do a switch. That's a pretty standard way of treating diabetic macular edemas. And let me tell you that almost 95% of the patients we can treat by this way. But often in our clinic, we have those 5% of unusual nut cases, which will not respond to the routine regime of treatment. So that's what I intend to discuss. Just take you through my journey of how I've evolved into how my practice has evolved. Shaurya, can I have a control on? Can I move forward from my side?
Yes, sir. Now you can, sir.
I can't move the slide forward.
So please try now.
No. Yeah. Okay. Thank you. So pretty much our experiences and our treatment choices depend on the input which we receive from different academic and non-academic sources. Most likely, a physician is supposed to rely on randomized control trials. The molecule which we want our patients to be treated with generally have to go through multiple RCTs, and we want them to be proven correct. We would always want these molecules to be recommended by one of the prestigious societies around the world. We want these molecules to have a parallel mechanism of action, probably have a multifaceted mechanism of action. And all this should translate into a very good real world evidence before we start using them into our patients. So can we go ahead? Sure, I still don't have control on this. Go ahead. All right, so this is my first case. This was a patient I started treating almost 7 years back. This is right and left eye of a gentleman who was seen in a diabetic screening. And we followed this patient over a period of next 3 years. He developed diabetic macular edema in both his eyes. Right eye, we were treating those patients, our patients with Lucentis at that point of time, and was pretty much a standard drug at that point of time. So his right eye received 3 injections of Lucentis in 2 years period, which responded pretty well to the treatment. And left eye, despite of injecting him on almost 8 occasions, was not responding to our satisfaction. And that macular edema kept on progressing over a period of next 2 years. Move forward. Thank you. So this is the picture in the left eye. You can see, despite of injections, this patient was actually worsening. And obviously, where my molecule was good enough to treat most of my patients, there was a situation where we could not have treated this particular patient with routine molecule, wanted something new in our armory, in our pharmacy. So at that point of time, protocol T was telling us loud and clear that we have this molecule called aflibercept, which was giving much robust and quick responses with earlier injections. And protocol T also showed us that we could actually achieve better returns in terms of letter gains over a period of 2 years. The drying capability of aflibercept is well proven and statistically significant as compared to the earlier 2 molecules, that is ranibizumab and bevacizumab, over a period of 2 years period when treated on a serial basis. And aflibercept could achieve this response because it had the capability to bind with all the ligands of VEGF receptor 1 and all the key ligands of VEGF receptor 2. So it was able to downgrade the downstream the regulation of VEGF receptor 1 and 2 both. Parallelly, it also had an impact on PGF receptors. And we know that PGF receptors have a significant role in pathogenesis of diabetic macular edema. So it had multi-pronged action that we always wanted. So we could control the inflammation, we could control the vascular permeability and neovascularization as well. Recent studies have shown that aflibercept actually gives you a long duration of action as compared to its competitors, especially the drug brolucizumab, which is the most recent one, we can say that. And its action on VEGF suppression is 19 days more than brolucizumab. It has an ability to bind with VEGF receptor A 100 times more than ranibizumab. So this speaks about the efficacy of the molecule itself. Well, coming to the recommendations, it's because of all the above illustrated reasons, URETNA actually in 2018 recommended as one of the clear superior molecules to treat diabetic macular edema in the practice scenario. So this particular patient, he received 2 serial aflibercept intravitreal injections, and we were able to flatten the retina, which we were not able to do with previous molecule. Going to a typical case 2 scenario, this is a kind of case we see in our daily practice. This was a patient who was seen in a diabetic screening again, and he had visual acuity of 20/60 in both his eyes on presentation, typical cystic diabetic macular edema. From our experiences in protocol T, we know that once the patient's visual acuity at presentation is worse than 20/50, aflibercept clearly emerges as a winner in terms of acquiring good visual acuity and gaining good letters at the end of the study, end of the 2 years, shall we say. So this patient was pretty straightforward. A single drug of aflibercept was good enough to flatten the macula in the right eye, and the same thing was also achieved in the left eye as well. Not every case works on such ideal scenarios. For example, we moved to case 3, patient with diffuse diabetic macular edema with a lot of exudates around the fovea and around the macula, especially the extramacular region. We treated this patient with Lucentis for a year. We didn't get any good response, and we moved to aflibercept. And we were expecting that we should have a very, very good response with aflibercept. But to our surprise, this patient did not respond at all to any of the drugs. Edema actually kept worsening, or it was what you call as recalcitrant diabetic macular edema. So I had to take a more conventional approach. I went ahead and did a focal laser photocoagulation. It's a modified grid laser, specifically targeting the microaneurysm bunch around the macula and the hard exudates. And you can see the hard exudates actually disappeared at the end of 6 months period. And now we started injecting this patient with aflibercept, and he has started responding. And you can see the central foveal thickness from around 500 odd has started coming down to 350 odd. So lasers, although are not first line of treatment by any means, but different studies have shown in recent times that 25 to 60% of the patients might still require some kind of macular laser treatment. The incidence of requirement of laser treatment in aflibercept group is lower in comparison with bevacizumab and ranibizumab. Case 4, a patient with diffuse diabetic macular edema, again, a very routine case, was not responding to Lucentis again. We moved it to a single shot of aflibercept. I was expecting a miraculous result, but to my surprise, the edema actually worsened. So I never expected this kind of response from any intravitreal injection, actually. So we went back to basics. We took the history from the patient. We realized that once we injected the patient, and when we saw the patient a month later, in between, this patient had serious alignments, and she was admitted in ICU with 1 week of intubation. He was already a known patient of diabetic nephropathy, and he had episodes of volume overload. So whatever you do, whichever route you take, unless you have a good systemic control of blood pressure, hypertension, and volumic control, you will not be able to achieve that desirable result. And that's exactly what EuroRetina also recommended. They stressed on this point of having a good systemic control while you're treating the patient. My last and final case was a very interesting case referred to me by one of my colleagues who practices medical retina. And he has been treating this patient with multiple kinds of injections over a period of past 2 years. He used both Lucentis and Eylea. Patient was responding to both the injections. He had also used one Osidex, if I remember correctly, but it was a recurrent kind of diabetic macular edema. So patient would, every now and then, it would discontinue the treatment and patient would come back to the original kind of maculopathy. This is how the patient was actually referred to me. I took a standard route. I went ahead and injected an aflibercept. Patient responded to it. Edema reduced. But if you see, the edema was actually changing in geography and the alignment. So this is called as fleeting type of diabetic macular edema, which happens in response to steroids or anti-VEGFs. When you analyze the OCT, you can also see a split in the layers of ILM and the neurosensory retina. And when you do an indirect ophthalmoscopy, you will also find a sheen onto the macula. So some of the retina surgeons, like me, do believe in operating such patients for pars plana vitrectomy with ILM peeling for non-rational diabetic macular edemas. So there is a whole different chapter on this particular topic. And although it's controversial, but in certain patients, selectively, it does work. 3 weeks following the vitrectomy and ILM peeling, this patient temporarily worsened. I gave him a single shot of Eylea again, and this was the response. 2 years down the line, now he's still maintaining the same kind of macular integrity, and he's never required any more anti-VEGFs after that. So EURETINA recommendations say that pars plana vitrectomy in non-tractional diabetic macular edemas is controversial, but it's not contraindicated. So to summarize, anti-VEGFs are the mainstay of management of DME. Aflibercept provide clinically meaningful visual outcomes with durability and definitely reduces the burden of disease. Systemic control is the key. Lasers and vitrectomy should be used in selective cases to optimize DME management to reduce the burden of the disease. Thank you for your attention.
Thank you very much, Dr. Mandeep, for this excellent presentation, as usual, with a very good and vast majority of experience. You take us from right to the left or from east to west and all different type of management. Thank you very much. There is just only one question came to my mind, Mandeep. So how do you figure out, or how do you deal with your patient diabetic macular edema when start coming to you with central retinal involvement? Just first time coming to you, and how do you build up your strategy in management of this patient?
Well, if this is a first time presented to me, Dr. Amri, I would go ahead and analyze the OCT. And these are the markers we are always looking for. We are looking for inflammatory markers there, along with diabetic macular edema. And first up, even if there are inflammatory markers present, we'll go ahead with serial anti-VEGF injections. Whatever one prefers, just go ahead with 3 injections, analyze the response. And if there is no response, I switch. I switch to Ozurdex. That's my drug of choice in terms of switch. If the patient still doesn't respond, I would go ahead and do wide field angiography for these patients. Many of these patients will have capillary non-perfusion areas, which is a seat for VEGF secretion. I do believe in angiography mediated PRP, peripheral PRP. I'm not talking about scatter PRP or normal PRP, but just target those areas beyond those capillary non-perfusion margins. And they have given good response, and then you can come back and start treating with anti-VEGFs again. But if you don't have those capillary non-perfusions, then just switch to steroids. Probably even go for combination insurance permits.
Okay, Mandeep, there is 2 kinds of patients. Patient came with macular edema with central involvement, but with good visual acuity, 6/6 or 6/9 or something. I mean, very good visual acuity. Or does they have worse? I think what you have talked about, it should be those they have a lot blurred of vision or decrease less than 60, about 200 or something, 40, above 40. But for those they are 6/6, it will be another way of management, right?
Yeah, those who are 6/6 and the OCT does not involve the fovea or the macula, I would just advise them.
Even if there is involvement, if there is a central involvement and 6/6.
Even if there is an involvement and they are 6/6, Dr. Amri, I would look around what is the cluster of microaneurysms around the macula. If I find just few discrete microaneurysms, I'll just advise them systemic control. I will not.
Yeah, this is what I want to listen to hear from you. So because we have not to forget, and in the beginning to ask the patient to have a good control of blood sugar at the same time, and the others either hypertensive or hyperlipidemia. Then we can just follow up with the patient. If it's still there and there is no decrease or no change, then we can go for a treatment. I would like to thank you very much, Dr. Mandeep, for this presentation. And
Thank
I
you,
think it's now the time for Dr. Mahmoud to take over and for the oculoplasty to start. Dr. Mahmoud, the floor with you. Can you unmute yourself, please? Dr. Mahmoud, you are on mute.
Okay.
Now,
I want to share just my screen.
okay. Already there is a screen share. Can you
Yes,
stop share, Dr. Mandeep, if you are?
sure.
It's been shared centrally, Dr. Amri. I'm not sharing the screens through the IT.
Okay. Soria, can you stop share everything and ask Dr. Mahmoud, give the space for Dr. Mahmoud? Okay, Dr. Mahmoud, now you can please share screen again. This is your screen, Dr. Mahmoud. You have to close the first one.
First one, issue.
Yeah, close this one.
Approve,
Okay.
approve.
Close, yes. No.
Yes,
No.
fine. Okay, we're all set. Thank you. Thank you. It won't go take a long. Hopefully, everybody is having schedule. And I want to just share with you this kind of module. I hope you like it. Actually, the first question is about periorbital relaxation syndrome, which include all except A, dermatochalesis, B, fatty herniation, C, canthal laxity, D, brow elevation. Could we have the poll, please, Shuria? Fine. Could we have the poll? Okay. So it seems people have succeeded to elicit the wrong except. So can Dr. Narish is around? Could you really comment on the periorbital relaxation syndrome?
I'm really sorry. It's not a syndrome I've ever heard of. So I'm actually at a loss.
It is just actually is the way we are aging. The aging, let us say, dermatochalesis, fatty herniation, canthal laxity, and brow descent. I mean, which is actually the four things that people speak about in aging. Just kind of, it's all about blepharoplasty is aging, rejuvenation. Okay, and this is what actually this is kind of. If you would like to tell us about really the aging phases.
Sure. You want me to say about the aging phase?
Yes.
Okay, so interestingly, of course, most people get dermatochalesis. Not everyone gets fat herniation.
Yes.
Some people have fat loss, but it's true that the medial fat pad tends to be more bulgy than the preapneirotic fat pad in a lot of elderly patients. People tend to be a little bit more ptotic, and canthal laxity is a possibility. Interestingly, with the brow position, I do see a lot of patients with compensatory brow elevation. So although, yes, all brows descend, and brows tend to descend more in the lateral third and the medial third. And that's because the frontalis, we think, stops at the lateral third, medial two-third junction in most brows. So the lateral brow tends to descend. But you do often see patients who have kind of a compensatory brow elevation.
Yes.
So
That's
And
true.
you often need to, if you're doing a blepharoplasty, for example, you have to ask them to close their eyes very tight and just relax and open their eyes. So like this lady's got a wildy brow, compensated brow, but it may be her ptosis.
Any one of the panelists would like to comment on this patient, or you just go on?
Yes,
Yes.
one comment.
Yes, please. Yes, Dr. Mahdi.
There is an upper eyelid ptosis, and the question maybe is during the same procedure for blepharoplasty, how to manage the ptosis. I think for these cases, we should manage it by anterior approach. Probably there is a disinsertion of the aponeurosis, so because it can be a point of discussion. How to correct ptosis in the same procedure with blepharoplasty. I think from my side, I think a anterior approach is a good approach.
Thank you. Thank you. I think we could go on. It is just anatomical, easy, actually, but I think it's basic question. And it says, yes.
Dr. Mahmoud,
Yes, Dr. Farzad? Yes.
can I make a quick comment on the previous case?
Yes, sure.
So in this case, we are seeing more than expected iridoptosis, and we have brow elevation. So I would like to mention that brow elevation may actually compensate for the eyelid ptosis
That's true.
in patient, although the patient has actually pre-existing brow ptosis. So if you just correct the ptosis, you may see that the brow is coming down. And after that, you need to correct the brow ptosis. And in this special case, I would like to especially look for any other reason for such eyelid ptosis. Thank you.
Fine. Thank you. Thank you. Actually, for this patient, I did upper and lower eyelid reconstructions and so forth. Anyway, we have to proceed. The second question is about in the lower lid, the medial fat pocket is separated from the middle fat pocket by the first inferior rectus muscle, B inferior oblique muscle, C capsulopalpebral fascia, D liquid ligament. It's a basic question. Okay. Can we have the poll, please? Yes. Okay. We wait the result of the poll. Which so simple question, so straightforward. But the idea is that less than 50% of the audience answered it correctly. So what do you think, Dr. Dr. Qasim? Dr. Qasim is around?
Hello, Dr. Mahmoud and everyone on the panel. It's inferior oblique muscle.
Yes.
Usually when I do lower lid blepharoplasty, I actually always mention to the patient that there might be a bit of transient diplopia post-operatively because of the post-operative edema and inflammatory process in the healing process. But the answer is inferior oblique muscle.
Yes. So, Dr. Farzad, do you think that doing blepharoplasty, lower lid blepharoplasty, and the local actually will save the patients a lot of complications, mainly injury to inferior oblique, because you ask him to look up when you really do the debulking of the fat, or the same thing if you really do under the GA, and actually, or the GA is more liable to get inferior oblique muscle injury. Dr. Farzad?
Dr. Mahmoud, I'm doing my lower bleph and actually mid-face lifting in most patients under local anesthesia, and I can control the patient with intravenous sedation and local injection of the anesthetic agent. So, but if you want to stay away from the injury to inferior oblique muscle, you should know where is it, and and locate it and actually keep away from damaging the inferior oblique muscle. So you may do something like a shoe shine test. Actually, it's a very simple test to show you the medial fat pocket and the medial fat pocket, and to make sure that you have released enough the fat pockets and the orbital septa, and also locating the inferior oblique muscle. So then you can be sure that you're not damaging the inferior oblique muscle in the patient.
Thank you. Shuria or Dr. Muhammad, there is some noise in the background. When
Dr. Mahmoud, we already solved it. It was coming from Dr. Narish, so we make a mute. That's why.
okay, fine. Okay, fine. So I should proceed to the questions now. Fine. This is, I think, it's very tricky, very basic. It's very important landmark. Such during upper eyelid blepharoplasty, an ophthalmologist identifies the peripheral arterial arcade. The peripheral arterial arcade here, okay? You now have, this finding means that the ophthalmologist has dissected down to which of the structure? Which one of these structures? A, orbital septum, B, molar muscle, C, levator aponeurosis, D, the conjunctiva. Now we are doing blepharoplasty. We are dissecting down to the kind of peripheral arterial arcade. Can we really have the pull? Fine. Again, it is less than 50% of the audience got the answer. Actually, right. Can you comment on it, Dr. Narish? If you are there.
Yes, I am here. So
yes. So
I'm sorry again. Is this what's called the tarsal arcade?
Well, yes. I mean, like the molar muscle.
Yes. So I don't know if my answer is right. I said molars.
I mean, like when you do ptosis, when you do
yes,
blepharoplasties, and you are dissect down to see peripheral arterial arcade, and you see it.
Okay,
you are just
that usually implies for me that I've gone too deep, because normally we wouldn't for a blepharoplasty go retroseptal, and this can sometimes be seen if you have levator aponeurosis dehiscence and you expose the tarsal arcade. But even then, you realize you're going to have to be very low at the superior tarsal border and too deep, because you've exposed a retroseptal structure. So you know that if you see this arcade, it's you're too deep and too low, probably.
Yes, this is the snag. I mean, if you see it, that means that there is levator aponeurosis dehiscence, either caused by you or it was there and it's apparent. So you should correct it. Once you see it, the arterial arcade, you should really do some tucking for the levator palpebrae superioris aponeurosis. What do you think, Dr. Farzad?
Can you please repeat the question? I'm not sure I got the question correctly.
It says, during upper eyelid blepharoplasty, an ophthalmologist identified the peripheral arterial arcade. This finding means that the ophthalmologist has dissected down to which of the structures?
Yeah, sure. And what?
And this is a molar muscle. Okay.
Yeah.
It is just you are just inside the levator aponeurosis, and you went into the molar muscle. So you have to really do repair for the levator aponeurosis at this stage.
Yeah.
Or okay, fine.
So you know, Dr. Mahmoud,
yes,
I've seen lots of these cases after blepharoplasty. The patient has been referred to me with different actually features of the eyelid ptosis. And as you mentioned, one of the reasons is that dissection too deep and cutting the levator muscle. Although it's not the only reason for post-blepharoplasty eyelid ptosis, but it's a real problem. And if the patient, actually, if the physician is discovering that something is happening, he or she needs to repair the levator muscle right at the time, but avoiding suturing the orbital septum. That's a serious issue and causes eyelid retraction after that.
Fine. Anyone would like to comment, or should I proceed to the first question? Fine. Now, this is should be easy question, but important as well. Is question number 4. A patient is evaluated for preoperatively for blepharoplasty surgery. Which of the following is not a relative contraindication to surgery? Now, this is a preoperative assessment. A, poorly controlled hypertension. B, severe keratoconjunctivitis sicca. C, insulin-dependent diabetes. D, arterial fibrillation with anticoagulation. So can we have the poll, please? Fine. Also, the questions, I thought it's not that difficult, but it looks like less than 50% of our audience got the right answer. So, where Dr. Mahdi Fandari would like to comment on this preoperative assessment. Dr. Mahdi is around. Okay. Dr. Farzad then. Oh, Mahdi is around.
Here.
Yes. And Dr. Mahdi.
To me, yeah.
Yes,
Okay.
yes. I
Yes.
listen to you. Yes.
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 My recommendation is for upper blepharoplasty, we should be careful about the different aspect, hypertension and general situation of diabetics, and offer, of course, anticoagulation. It's all the elements is very important to have a good situation for the surgery. So I think we should have a very good control of each element of this for this patient.
And look for dry eye problems and control hypertension and see the patient is anticoagulant or not and so forth. Fine. Anybody would like to comment on this? I proceed?
Dr. Mahmoud?
Yes, Dr. Farzad.
So it's really important. This is a really important actually point that all surgeons should consider, even though you haven't post-operative lag ophthalmos, still your patient with pre-existing ocular surface disease like moderate or severe dry eye may experience actually some problems after the upper or lower blepharoplasty. So it's really important to control the patient in terms of the ocular surface disease before proceeding to the surgery. And for taking anticoagulant agents, it's really important because this is one of the major risk factors for post-operative orbital hemorrhage that can be blinding in some patients. So if you're opening the septum, there is an increased chance for actually directing the blood into the orbital space and causes significant orbital hemorrhage and a loss of vision. So it's really important to control that situation before proceeding for the blepharoplasty. Unfortunately, I've seen cases, numerous cases, that was undiagnosed anticoagulant usage by the patient, and after bilateral, upper and lower blepharoplasty, the patient got blind. So it's a really sad thing and should never happen. Thank you very much for this question.
Thank you. Thank you.
Dr. Mahmoud, just to
Yes,
follow
yes,
up on
please.
Dr. Farhad, if you don't mind, just for the panelists in terms of a discussion. So there's been different kind of papers in the literature discussing the anticoagulation, when to stop it, between aspirin, for instance, and Plavix, or the recent anticoagulants in the market like Xarelto. I'm just curious because I've asked several colleagues of ours, like the cardiologists and vascular surgeons, in terms of the anticoagulation and how long before should we be stopping them. So I'm just curious to see if there's a protocol that the panelists use in terms of what days do they, how long before the surgery they stop it, and when do they ask the patient to go back on it?
Okay. Dr. Naresh, the eyelid man.
Okay, so the stopping or cessation of any anticoagulation is not dependent on the ophthalmologist, but in consultation with the physician. So I usually say to the patients, if you have a discussion or let the physician have a discussion with me, it is in your interest to be optimally in a situation where you're least likely to bleed, because this is a cosmetic procedure. Now, if the cardiologist says that no, they can't come off their aspirin, or they can't come off whatever else they're on, I will then have a discussion with the patients to say, look, this is the situation. I am quite happy on the whole to do pre-septal surgery on anticoagulation. The only thing I do differently is that I use the Colorado needle on the skin, or a coagulative incision as I go along. If there were kind of with any other issues like hypertension, atrial fibrillation with any or diabetic in conjunction with the anticoagulation, I probably wouldn't do a retroseptal operation because I think if you have a retroseptal bleed in the presence of one of those, it's very difficult to control. I mean, we can all have retroseptal bleeds, but to control that and do a cosmetic procedure and potentially blind a patient on one of these compounds, I don't think will be in the interest of anybody. So I usually discuss it with the physicians. If they can stop it, I will take their guidance. If they can't stop it, then I will do pre-septal surgery, like upper blepharoplasty, but I will not do retroseptal surgery.
Okay, thank you, Dr. Naresh. We proceed. Yes. Anyone? Okay.
Yes.
We have a long way to go. Anyone like to comment on this? Okay, so then proceed.
Probably the question of anticoagulation. The question is for the lower eyelid, when we have a fat excision to do and the risk of hemorrhage, we have to be retroseptal. And in these cases, it can be really a problem. I don't think, Naresh, what you do in these cases for lower upper blepharoplasty when we can stop anticoagulation.
Yes,
you know what?
yes.
I would not, on the whole, do a retroseptal or lower blepharoplasty on a patient who's poorly controlled or on, especially the newer anticoagulants. Aspirin, I don't know. I'd have a debate on aspirin, but anything else, I would really steer away. If I can, I'd steer away from any lower blepharoplasty.
Okay. Thank you. Thank you.
Dr. Mahmoud, can I make a
Yes,
quick
yes,
comment?
sure,
To
Dr.
bring up,
Fawzi.
I realize our colleague is asking about how long should we stop and how long after surgery can we restart the anticoagulant agents. So in this case, we should remember that we have different half-lives for different kinds of the anticoagulant agents. Like for warfarin, it's said that you need to stop the warfarin at least 3 to 5 days before surgery, but our protocol is just to check INR to make sure that your INR of the patient is within normal limits. And it's really important to understand that if you stop anticoagulant for surgery, you should remember that for a reason it has been started, like atrial fibrillation. So if you discontinue the anticoagulant agent, you may increase the chance of the thromboembolic phenomena after the operation. And it's not always in the immediate pre-operative era. it has been reported that up to 3 months after the surgery, the risk of the thromboembolic phenomena is increasing in these patients. So our protocol is to check the risk with the actually physician that started the anticoagulant agent. If the risk justifies for a cosmetic surgery, I will go for that. If it's not, I will never ever discontinue the agent myself. But for the duration, so for warfarin, I told you about the INR. If your patient is taking Clexane, that's anticoagulant agent with a shorter duration of the availability in the body, it takes like 24 hours. So if you just stop the Clexane two days before surgery is enough. For different actually agents, it's different. So you should check if your patient is taking what. And I would like to make a final suggestion here. If you're operating on a patient that the patient needs to be operated and the patient is taking anticoagulants, if your patient is developing bleeding for agents like Clexane, enoxaparin, or something like that, you can not stop or reverse the action of the anticoagulant agent. So for these cases that you need to do operations, you can switch the patient on short molecular weight, low molecular weight heparin. So in the case that you have bleeding and the bleeding is really important, you can prescribe protamine to reverse the action of the actual anticoagulant agent. Thank you.
Thank you, everybody. I think we have to proceed. Fine. It's actually easy one, straightforward. It's a preoperative evaluation locally of the lower lid before blepharoplasty and should include all except snapback test, distraction test, and Jones test, and tear trough. Okay, can we have the poll, please? Also, you want to make sure the patient is safe locally, at least. Yes, fine. Almost more than 50% of our audience got the right question, so at least they are aware of to do things. Fine. So one of the panelists, if would like to comment on this, if you want to, or anybody would like to comment on this, snapback test and distraction test.
So can I make a quick comment on this?
Yes, yes,
I'm
please.
allowed?
Yes, Dr. Farzad.
So it's essential to check for lower lid laxity, especially in the cases that you are planning to do lower blepharoplasty. And we have two essential tests for lower lid laxity. One is snapback test that you beautifully mentioned here, that you just pinching the skin, take away the lower eyelid from the globe and just release it. If it just snap back quickly, it's normal, otherwise abnormal. If you just pull down the lower eyelid and it's actually distracting more than 7 millimeter from the globe, like you measured here, it's considered like lower lid laxity. Otherwise, below 7 millimeter, it's not lax. Why it's important? Because if you have masked lower lid laxity, what does it mean? It means that you have no scleral show there, but still you have laxity of the lower eyelid. After blepharoplasty, even with minimal touch of the orbicular circulated skin, and even just touching the conjunctiva, you may scleral show after the surgery, or worse than that, retraction of the lower eyelid, and you need to plan for actually a tightening of the lower eyelid in the case that you have kind of laxity, and even worse in the cases that you need to do for lower blepharoplasty and you have a borderline test. Still, I prefer to do lower tightening for these patients.
Thank you. Thank you. I think there is another question also about eyelid retraction. Now, fine. It's a question 6. It is actually about the technique of the lower blepharoplasty itself. All true about regarding blepharoplasties, one is false. So lower lid blepharoplasty is most commonly performed for cosmetic conditions. Upper lid blepharoplasty is most commonly performed for functional reasons. C, difficulty in reading is an indication for functional lower lid blepharoplasty. D, cosmetic upper eyelid blepharoplasty often requires skin rejuvenation and chemical peels. Fine. Can we have the poll, please? So, who would like to come in and wallahi, well, actually the number D, which should be the false one, but I would like to hear the actually the panelists comment on that. Okay, please. Dr. Farzad would like to share, or Dr. Yes, Dr. Farzad. Do you
So
do any
yeah.
cause yani kind of skin rejuvenation, chemical peels and whatever for the
Yeah.
upper eyelid?
Yes, yes, very much. So in the case that you have wrinklings of the eyelid skin, both upper and lower, you may go for peeling or for fractional CO2 lasering. So I prefer to correct the fine wrinklings with laser or chemical peels instead of just removing the skin. So it's why it's that, because it controls that wrinkles very pretty good, and it brings back the actually young tone to the skin. And yes, I believe that chemical peeling and CO2 laser is very beneficial adjuvant for incisional surgery.
They are beneficial for the lower lid, actually, chemical peeling.
Exactly,
and
exactly.
chemical more for the lower lid more than the upper lid.
Exactly.
Support. Okay. Yes.
Yes.
Dr. Naresh, Dr. Mahdi.
Yes, for the
Yes.
upper lid, this wrinkled skin is for the upper lid is mainly due to the slight of volume loss, and so it's more the indication for fat grafting or peeling than the skin rejuvenation.
Yes. Dr. Naresh is around.
I'm around.
Yes, please.
The thing that C was interesting for me, and that difficulty in reading is an indication for functional lower lid blepharoplasty. That's not something I've come across. I'm not sure how lower blepharoplasty would help you read.
It means dermatochalesis. It
the
comes
lower
in the way. Yeah.
Okay.
And fatty
not something-
herniation, whatever. That's okay.
Okay.
Fine.
Dr. Mahmoud, I agree with Naresh that I believe in, although in my experience, in most cases with blepharoplasty, actually cases, the upper eyelid ptosis or upper eyelid severe dermatochalesis is associated with the reading problems for the patient. Why? Because when the patient looks down, relaxes the frontal muscle, and the patient needs to read something, the visual field may be disturbed. But I'm not sure about the lower eyelids. I agree with Naresh.
Yes, thank you. Now, question 7 say regarding blepharoplasty techniques. One is false. Transconjunctival incision is preferred more than subciliary incision in lower lid blepharoplasty. B, at least 20 millimeter of skin should remain between the inferior border of the eyebrow and the lower eyelid margin in the upper lid blepharoplasty. C, during blepharoplasty surgery, in a patient with a dry eye syndrome, the surgeon should preserve orbicularis oculi muscle. D, the amount of excess skin to be excised is determined by pinch technique. Can we have the poll, please? I myself, I didn't like this question, but it was there in the board, and so I put it to clarify things. Okay, and actually, good that it got 35% audience clear. What do you think about this? At least 20 millimeter of skin remain between inferior and so forth is the right one. What do you think? I mean, any one of the panelists would like to comment on this question?
Actually, I'm going to say something. I think they could all be
Please.
false.
Yes.
I mean,
Okay,
when
fine.
you say
Yes,
a transconjunctival incision is preferred, of course, it depends on who you are and what you're able to do. If you say 20 millimeters.
It depends on the patient, come on the patient.
And it depends on the patient and the
skin.
surgeon.
Okay.
If the surgeon's never done a transconjunctival blepharoplasty, then a transcutaneous is preferred. And also the 20 millimeter skin rule is actually, I think, whenever you have a dictate about how much that you give to everyone, of course it's not true. I mean, we have looked at 100 patients, and there are patients who've had less than 20 millimeters left because their brows are incredibly low, and they've always had low brows.
20 millimeter. I mean, who put the questions? He means that it should be 21 millimeter. I mean, like look, 21 millimeter
honest,
is okay.
I have a patient,
20 millimeter is not okay. How it comes? I mean, this is why I kept it like this.
Yeah.
And this is what they want. But actually, there is a report that 20 millimeter might work anyway in some patients. Okay.
Yeah, exactly. Or 19.
Or 90. Okay, maybe. Yes, as well. Yes. Okay. And also about the dry eyes, what do you do? I mean, you preserve orbicularis oculi muscle. Is it right, or is it not right?
Again, I'm not sure what dry eye syndrome means. It depends on the severity. But look, when it comes to orbicularis, I'm not 100% convinced that taking a strip of orbicularis, 20% or 30%, makes that much contribution to the long-term eyelid closure. It may be transient, but I'm not sure, because as I always say in these questions, I recall the days when I used to take out 90% of the orbicularis for blepharospasm, and the next day they would close their eyes completely. So I'm unsure that if you take a tiny strip of muscle, or if you cauterize, I mean, it's no different if you cauterize a bleeding muscle severely, that it won't have the same impact. So I'm not sure about the orbicularis being that important. So I don't know is the answer.
Yeah. Dr. Mahmoud, I have a comment about a pinch technique. I'm a little bit uncomfortable for this technique with the conventional approach, because pinch technique in the conventional approach is to evaluate the maximum of amount of skin reduction. But the aim in upper blepharoplasty is not to remove the maximum of skin, excess skin. The aim is to remove the proper amount and the adequate amount of skin, excess skin, not the maximum of excess skin. This is a very important point, because evaluation, how much we should remove in the upper eyelid during blepharoplasty, how much we may remove skin, is very important point. And for this point, the aims is to reach the ideal pre-tarsal show and not to remove a maximum of skin.
Thank you, everyone. Fine. Okay. Now, question A8. regarding lacrimal gland prolapse. Says A, is it a frequent finding in dermatochalasis? B, will disappear after upper blepharoplasty. C, it requires excision. D, it requires a separate procedure later. Can we have the poll, please? Fine. Okay. Actually, number A, and 40% of the audience got it. It's a frequent finding in dermatochalasis. But can you comment on that, Dr. Dr. Qasim?
Dr. Mahmoud. Yes, I agree. This was my answer. It's a frequent finding in dermatochalasis. And usually, since you're opening up and doing an upper eyelid blepharoplasty, you solve the solution at the same setting, meaning you do lacrimal gland repositioning and repair. And I fix it to the superior lateral orbital rim with a deep, I usually use 4 vicryl bite because I like the needle and I like to secure it quite well to the orbital rim. But my answer was yes. It's a relatively frequent. I wouldn't say it's a relatively frequent finding in upper dermatochalasis.
Fine. How do you fix it, Dr. Mahdi? Lacrimal gland prolapse.
Yes, I fixed it during the procedure with vicryl also, with vicryl.
Vicryl? Vicryl will do with you?
Yes. Yeah, only with the vicryl. Yes.
Fine. What do you think, Dr. Nareesh? Please.
I think the most important thing for this is that it is true that some studies show that up to 40% have a degree of lacrimal gland prolapse, but it is not important to retroplace because the isolation and putting the lacrimal gland back to the correct position is a complex operation that those who do blepharoplasties occasionally, I do not think, should undertake. It's more important to explain to the patient what's going on. So if you say there's a little swelling here, but you can hardly see it except when you look left or right or up and down, I would say that most people would accept it. Of course, if it's the major concern of the patient and they said, what I really come here for is this big lump here, then you have to address it. But if you have a small degree of prolapse and you don't want to remove it, then what you should not do is take the orbicularis out in that area, because the orbicularis is 2 things. One, it acts as a cushion to hide it. And if you take the orbicularis out, then the prolapse will be more obvious because it'll show through the skin. And secondly, the orbicularis is actually, of course, a contraction device. So it makes the lids a little tighter. So don't take the fat, definitely don't take the orbicularis over that. But you can explain to the patient that a small swelling in this area, if it doesn't bother them, and that what they're really focused is the hooding on their eyelash, then I would not remove it. I would just put some cautery to the septum, but don't take away the orbicularis.
Fine, Dr. Farzad?
Yeah, I agree with Nareesh, absolutely. And it's not necessary to fix any degree of the lacrimal gland prolapse. And in the cases that there are moderate or severe prolapse and causes bulging in the right upper side of the eyelid, it's important to fix it. And I fix it with non-absorbable sutures. My preference is Prolene. And one important thing, if you're talking about how is it frequent, it depends on the age group that you are dealing with. If you are dealing with younger age, like 40, 50 age groups in blepharoplasty, the frequency is something like 15%. But if you're dealing with 70s, 80s patients, you have a much more frequent problem. Up to 60% of patients may have moderate degrees of the lacrimal gland prolapse. And it's really important. Why? Because if the surgeon ignores to fix a moderate or severe lacrimal gland prolapse after the operation, the patient will find out that bulging over there and will be unhappy after the surgery. So it's really important to actively search for that before the surgery. And how you do that, you need to just push your globe, retroplace the globe and look at the bulging over there. And you may do it both the patient sitting and the lying down, and actually search for any signs of the prolapse over there. And I believe you have some slides to show us.
If no, I don't have, not now. Actually, the problem is that when it is asymmetrical, so it's in one side more than the other. It can be really, it can cosmetic blemish. I fixed them by Proline, and I stitched it into capsule of the eye, of the palpebral portion. I stitched it back into the perosteum inside the orbit, the lacrimal fossa. Proline. I used 2 stitches. I used the Vicryl, and then I was disappointed because it seems it melts out early and so forth. I don't know what happened. This is what I do in it. So, any would like to comment more, or should proceed? I think we should proceed. Fine. It is easy, straightforward. We might not. The most likely outcome following inadvertent suturing of the orbital septum into the subcutaneous tissue while performing blepharoplasty is ectropion, lid retraction in down gaze, entropion, and blepharotosis. So it is inadvertent suturing of the eyelid, the subcutaneous tissue. So suturing the orbital septum by mistake into subcutaneous tissue while performing blepharoplasty, it will cause lid retraction and down gaze. So more than 50% got it. I mean 64%, and this is the right answer. So it's easy. I think we should proceed with another question. Thank you. Anyone would like to comment on this, or we should proceed? I think we proceed. The most significant complication of blepharoplasty is, this is very important, orbital hemorrhage, diplopia, overcorrection, and cellulitis. Can we have the poll, please? Fine. Okay. So we have almost like or between orbital hemorrhage and overcorrection, and this needs to be clarified. The most significant, let us say, significant complication of blepharoplasty. Dr. Mahdi, what do you think?
Dr. Mahmoud, I think Dr. Mahdi lost connection.
Lost? He told me he would be there. He has something to do. Okay, مش مشكلة. Dr. Farzad? You are around?
Yes, Dr. Mahmoud. Yeah, I'm around.
Yes.
So yeah, all of these are important complications after blepharoplasty, but the most dreaded and most the worst one is orbital hemorrhage that may end up with the blindness. And in the incidence is different, depends on the age and the condition of the patient in terms of systemic disease, drugs, or something. But overall, the incidence of orbital hemorrhage after blepharoplasty is something like 1 in 2,000 in some degrees of hemorrhage, and it's much more prevalent for the lower bleph than the upper bleph. And unfortunately, the incidence of the permanent visual loss, some degree of visual loss after orbital hemorrhage after the lower bleph is something 1 in 2,000 or 2,200, something like that. So it's really important to avoid that, and it's really important for the surgeons to consider the most frequent time after operation that hemorrhage happens. It can happen during operation or after operation, and the most frequent time is 8 hours after the operation, and in the 8 hours, it's most common in the first 4 hours. So it's really important to keep the patient under observation in this gap, and you should actually make a connection with your patient in terms that the patient develops pain, decrease of vision, proptosis, hemorrhagic chemosis. You need to immediately check your patient.
More questions about this issue actually coming. Yeah. But the idea is that overcorrection, is this something called overcorrection in blepharoplasty? Dr. Naresh?
Okay, so I mean, by overcorrection, you mean it's, I suppose, any aspect of the blepharoplasty can be overcorrected. Too much skin resection, too much
this is complication
fat.
Then.
Yeah.
This is complication.
Yeah, the complications of overcorrection is if you take too much skin, it's retracted. Yes. If you take too much fat, it's hollow. But there are two distinctly different complications. One complication is an aesthetic complication, overcorrection. One complication is a functional issue, blindness potentially. So of course, orbital hemorrhage should be, in my opinion, the potential of losing vision, a much more serious issue than an overcorrection, which is an aesthetic issue. So when patients come after blepharoplasty and they are unhappy, I always say to them, what are you unhappy? If they're unhappy because they can't close their eyes, they're losing their vision, that's much more, important in the sense of correcting than if they say, I don't like the little bump on my lower eyelid, which is an aesthetic issue. So for me, orbital hemorrhage would be far more important than any other aspect.
Thank you. To proceed, there are a lot of questions about the complication. And complication of blepharoplasties include all except superior rectus muscle weakness, epiphora, lower lid retraction, and ptosis. So can we have the poll, please? Question. Yes. Fine. Okay. So at least more than 40% good superior rectus weakness doesn't happen. It's not related. Dr. Qasim, would you like to comment on this?
I mean, a lot of complications can truly be avoided with blepharoplasty, but mainly I prefer when you're doing, for instance, lower lid blepharoplasty and you take out too much of the anterior lamella and cause a bit of cicatricial ectropion, or lower lid retraction for that case, which can happen with both upper and lower. Ptosis, as we previously discussed, if there was inadvertently injuring the levator from the upper eyelid, this can cause the patient ending up with ptosis post-operatively. But the superior rectus muscle, I think, from an anatomical point of view, you're operating quite a distance, or should be operating quite a distance away from it. So the likelihood of this happening is virtually minimal.
Great, thank you. I think we proceed for more important questions. Now, this question. This is what is the most common complication of a transcutaneous lower lid blepharoplasty? Lower eyelid retraction, Biogenic granuloma at the site of the incision, lash loss, D, bacterial infection at the incision site. The poll, please. Yes, and 64% of our audience got the answer right. That this is this one of the kind of poor women who were seeking really general ophthalmologists, you know, doing blepharoplasties, and they was enthusiastic, more enthusiastic to remove more skin. So they ended up in eyelid retraction and so forth. Now, the question is that what do you do in these cases, Dr. Nareesh? How do you deal with eyelid retraction? Dr.
What do
Nareesh?
I do for, sorry, I just missed that. What was the, you asked me, what do I do for this retraction?
Oh, yes. Now you had got this complication.
So if
For
I have a
example.
low, so if a lower lid retraction occurs, then you need to assess why you have the retraction. So the retraction is two things you have to take into consideration: when it occurred, and then anatomical correction. So if your patient says, my eyelid was completely fine after my lower blepharoplasty for the first week, and then it retracted, it usually implies that the anterior lamella was okay, but this is middle lamellar fibrosis. Okay. Whereas if the patient says immediately post-surgery, my lower eyelid was retracted, it usually means that there was anterior lamellar deficiency. Too much skin was removed, or canthal laxity wasn't addressed, etc. Now, in terms of correction, after waiting and pushing up, unless they have a functional problem, you can't wait, then you correct according to the lamella. If it's anterior lamellar deficiency, you need to do more skin, best with a flap from the upper lid. If not, then a skin graft, if you must, but that doesn't look so good. If in middle lamellar fibrosis, my usual approach is a transconjunctival approach to disinsert the scar through the middle lamella and then inject 5-FU on a weekly basis and depomedrone at the time of surgery. So my main thing about lower lid retraction transcutaneously is first to ask the patient, when did it occur? An immediate lower lid retraction implies inadequate support of the canthus and or inadequate excess skin removal. Otherwise, it's middle lamellar fibrosis, and it may get better by itself.
Thank you. Thank you. I think we have to proceed with this. Now, another problem called regarding tear trough deformity. All are true except is it due to descent of the Suf and malar fat bed? B, it requires volume addition. C, results in a double convexity appearance. And D, can only be corrected surgically. So can we have the poll, please? Okay, fine. So another times our audience are doing very good with the blepharoplasties, and they are answering rightly. There are many means of correcting the tear trough deformity other than surgically. Dr. Farzad, would you like to comment on this question?
Yes, actually, tear trough deformity is a real important aesthetic issue that should be actually assessed and managed by the aesthetic surgeon. So very briefly, you can handle it both surgically and non-surgically. Non-surgically, you can fill it by the fillers, especially with the HA agents. And although I cannot totally preclude using the fat, but my preference is HA, hyaluronic acid agents. And why it happens, it's because of the actually changes, the aging changes in the infraorbital region. And very briefly, we have tight adhesions between the skin and the actual ligaments behind that. And those ligaments stay attached over that, but we have actually descent or actually displacement of the fat tissue under that, and it causes the bearing of the bone over that and causes deformity like teardrop deformity or infraorbital hollow. So how much it's important accounts for post-operative unhappiness of the patient. We had a study on that, and we were surprised to see that most patients didn't notice the teardrop deformity before the operation, but after the operation, they pointed out. So it's really important to discuss and counsel the patient about the teardrop deformity before going for the actual lower bleph or mid-face aesthetic procedures. Thank you.
Okay, true. I would like anybody to comment on this, or I proceed? Okay, then I proceed. Fine. This is now a few hours following bilateral blepharoplasties. A patient complained of sudden pain near the left eye. Removal of the dressing and local examination reveals tense and echomatic left eyelids. The first step would be the management of this case. A, treatment with ice packs. B, visual acuity measurement and check pupillary responses. C, check corneal sensation for a possibility of cavernous sinus thrombosis. And D is that you open up the wound to release a possible retrobulbar hemorrhage. Can we have the poll, please? This patient. Fine. Almost, yes, our audience got it. It is the B, it's the visual acuity measurement of pupillary responses. Check the pupil is very important, crucial. Would you like to comment, Dr. Farzad, because you were speaking about orbital hemorrhage and such?
Sure, Dr. Mahmoud. So it's another important case that you presented. So retrobulbar hemorrhage needs immediate diagnosis and management. So the first step to find out if this ecchymosis, this hematoma, is it intraorbital or it's preseptal. So it's essential to check the extraocular motility, visual acuity, relative pupillary abnormalities, proptosis, resiliency of the globe. You just push the globe behind and check if it's stiff or it's resilient. So you can find out clinically if there is a possibility of the retrobulbar hemorrhage or not. So if you have retrobulbar hemorrhage, you should immediately actually start management on the bedside. You need to open the wound, let the blood to coming out from the wound if possible. Otherwise, you should do a cantotomy, infracanthal septal if not successful, supercanthal still, if it's still not actually increasing the visual acuity, you may need to do for orbital decompression. These are the steps. And I'm not sure if AC tapping, corticosteroids, mannitol, or something, acylzolamides, timolol, have any worse in this situation if they do not harm. And it's usually asked if we can go for injection of the mannitol in these cases. I can say here for my dear colleagues that mannitol has a bimodal phase. The first phase, when you inject the mannitol, it increases the osmotic pressure in the intravascular space. It draws the water into the intravascular space. So you will have shrinkage of the intercellular space, decreasing the tension inside the body, inside the orbit. But after a while, that tiny osmotic agents diffuse inside the intercellular space and draws water. And so it aggravates the situation after that. So I do not think it's wise to prescribe mannitol for these cases. The surgical management is the necessary step. And I would like to mention, if your patient is taking like anticoagulant agents, these patients are really tough to manage. If you do cantomycantolysis, you may have such bleeding that you need to control that. You need to reverse the antithrombotic agents. So you need to admit the patient and have everything in hand, like cautery, like anything that's necessary for adequate hemostasis. You need to have a good orbital surgeon in hand to control the bleeding for you.
Thank you.
Thank you.
Thank you. Thank you. Proceed. Now it's a no picture here, but complication of blepharoplasty surgery. One is false. Loss of vision usually associated with the lower lid blepharoplasty more than the upper lid. That's more serious complication are associated with the lower lid blepharoplasty than the upper lid. B, TED, the thyroid eye disease, is regarded as a risk factor for post-blepharoplasty surgery orbital hemorrhage. C, pressure dressing should be conducted directly after surgery. D, urgent orbital decompression, then high dose of IV steroid is the management of choice for post-operative orbital hemorrhage. Can we have the poll, please? So one is false. Okay, fine. Fine. Okay. Wallah, it seems very difficult question. Now, Dr. Nareesh, would you like to answer this question? How to comment on it? Actually, the idea is that C should be pressure dressing should be conducted directly before, immediately, after surgery. We don't do any pressure dressing after case of blepharoplasty. Shouldn't be done. I mean, this is wrong, but all other option is possible. So I don't know how the loss of vision associated with lower lid blepharoplasties. That's true. Fine. Can you comment on this, Dr. Nareesh? This question, please. Dr. Nareesh, is that with us? Okay. I am here alone. ولا إيش? Dr. Nareesh is not around. Okay, Dr. Farzad.
Yes, Dr. Mahmoud, I'm here.
Yes, please. Can you
so
comment
I
on
can
this?
make quick comments for that, as you asked. Actually, pressure patching after blepharoplasty is not advised. I usually, in my practice, I keep the eyes open after the blepharoplasty so the patient can understand if the vision is decreasing, and they can actually see if the patient is developing proptosis or actually progressive ecchymosis after the surgery. This is the first thing I would like to pinpoint. The surgeon should consider the risk factors. If you have risk factors, you should take greater care for your patient in terms of the post-operative complications like post-operative orbital hemorrhage in such patients. As I mentioned, the steps for controlling of the orbital hemorrhage that's associated with orbital dysfunction, like decreasing visual acuity, is stepwise. The first thing is open the wound to allow egressing of the accumulated blood from the orbit. If it's not actually associated with improvement of the patient, you can proceed with lateral canthotomy and cantolysis, septolysis. And if it doesn't work, you can go for orbital decompression as soon as possible. So the other thing you should actually mentioned here about intravenous corticosteroids, high dose intravenous corticosteroids. So anecdotally, I've heard that many colleagues say that in these situations or any orbital problems like this, they actually advise injection of the intravenous high dose intravenous corticosteroids. But I'm not sure if there is solid evidence about the beneficial effect of the intravenous corticosteroids in this situation. So I do not, myself, I do not prescribe intravenous steroids for my patients with orbital hemorrhage after blepharoplasty.
Of course. And also the audience commented on A as being wrong. I mean, no, the lower lid blepharoplasty has more tendency to produce complications than the upper lid blepharoplasty. Upper lid blepharoplasty is cosmetically very important, and technically could be more apparent and sound, but actually it's associated with much less risk of complications as regard hemorrhage and let us say very apparent or very peculiar or significant complication. What do you think this Dr. Qasim معنا? Qasim?
معك دكتور محمود.
Yes.
I agree completely, especially with the low lid, you tend to see how move more fat or potentially manipulate with more fat, which is very vascularized, as we all know for those. So the risks definitely in lower lid blepharoplasty in terms of retrobulbar hemorrhages are much higher than the upper eyelid.
Fine. Okay. I will proceed with to the 16. Fine. And question 16 is if a few hours following blepharoplasty, the patient complains of pain and reduced vision, noticed to have proptosis and abnormal pupillar reaction, and the most appropriate step to take is A, CT scan, B, canthotomy and cantholysis to release retroorbital hemorrhage, C, IV steroid for compressive optic neuropathy, D, observation and pain management. The point is fine. So it was straightforward. Everybody answered almost 68% canthotomy and cantholysis to reduce orbital hemorrhage. So we will proceed because everybody is getting to the one. Now it's this 17. This is a tricky question regarding persistent conjunctival chemosis following blepharoplasty. All are true except it requires pressure bandage. B, it caused mainly by lymphatic obstruction. C, may need surgical excision. And D, occurs more in diabetics. So Dr. Farzad, أقول لو خلص خلينا yes. أو قسيم. Fine. Okay. Also, this question has been answered poorly, and the answer it occurs more in diabetic. No, nobody showed that it's more in diabetics. Okay, and actually, but it It doesn't require a bandage. It's caused by lymphatic obstruction, may need surgical excision. Yes. Can you comment on this, Dr. Farzad, how you deal with chemosis after blepharoplasty?
Actually, prolonged chemosis is really frequent after lower blepharoplasty and mid-face lifting. But if you have severe chemosis or long-standing chemosis after the lower bleph, upper bleph, or preorbital procedures, the three major things should you consider as etiology of this chemosis. First is the inflammation. You should search for if there is any reason for a prolonged inflammation of that, sutures, infection, or something. The second one is venous stasis and the impaired drainage of the venous system, like in thyroid patients, tumor patients, or patients with some vascular compromised state. The third one is the lymphatic drainage actually damage during the surgery, especially for the cases that you're dealing with the lateral canthal, medial canthal, or extensive periorbital surgeries. So in this case, you need to actually formulate your decision plan based on the etiology of these agents. But broadly, if you have mild chemosis, you should start with just active observation, lubricants, low potency steroids, and like that. But if you have long-standing severe and moderate chemosis, you should consider more aggressive things. If you have like lymphatic drainage problems, it's not a good idea to proceed for further surgical interventions. You may have worse situation if you do more surgeries, if you have lacrimal drainage problems. But if you have like inflammation or vascular problems, you may consider doing pressure patching, lateral blepharoplasty for a while, or hand resection after actually follow-up and inadequate actually response of the patient. And it's important to consider the ocular surface problems in these patients. The patient may develop or may have previously ocular surface problems like dry eye. You should make sure that you have controlled the ocular surface problem as well.
Can you predict these patients, this kind of patients who are likely to have this kind of chemosis?
Yeah, actually, I may see that the patient has both upper and probably lower and lateral canthal surgeries. So I assume it's both lacrimal, both lymphatic and the venous stasis problems. So in this case, with the moderate chemosis, I will start low potency steroids, lubricants, pressure over the eyelid or patching of the eyelid, a temporary lateral blepharoplasty, and after that, I will decide for proceed for more interventions or not. So in this case, I prefer not to just jump to the surgery.
Dr. Naresh is around?
Yes, I am. Sorry, I lost you for a while, but I'm back.
Okay, very good. You came in the right time. Yes.
For chemosis, there are what we call pre-existing, perioperative, and post-operative reasons. So pre-operative reasons, I would say there are some patients who are more likely, those who smoke, who've had surgery before, diabetics, people with floppy eyelid syndrome. So there are categories of patients that have a higher risk. Also, those patients whom when you examine have a conjunctival chalasis or who've had inflammatory eye diseases are much more likely, especially anterior segment diseases. Dry eye is another. The operation per se, the more traumatic the operation, more likely they are to have chemosis. Upper and lower blepharoplasty, especially if transcutaneous upper and lower blepharoplasty, and the incisions on the lateral point come close to each other, and there's been canthal disruption, have a higher rate. And then anything post-operatively, the classic is lag ophthalmos. For chemosis management, I always say to my trainees, there are two types. If there is lid malposition, if the chemosis is so big that it's pushing your lid out, then you must intervene surgically early. Because if you wait 3 weeks and the lid is being pushed out, your lower lid will never go back to where it was. So early intervention for lid malposition. Otherwise, medical management, lubrication, and occasional steroids. I use, if I've drained them, I use a large 20 millimeter bandage contact lens, temporary tarsorrhaphy with a single stitch, and a pressure occlusion padding overnight sometimes. But if it recurs, then you have to wait and see what happens. But if it causes lid malposition, then you should intervene early.
The interference, how you intervene. I mean, like, I have never done surgery for this kind of chemosis. And
Okay, so
maybe once or times after ptosis, but not with blepharoplasties. You
okay,
do
chemosis?
Yes.
No. So the simplest thing is to put topical anesthesia, put a cotton bud full of anesthesia at the infralateral bit, ask them to look upwards, and on the slit lamp, what I will do is use a fine-tooth forceps, cut a radial cut in the inferior bulbar conjunctiva. And then what you can do is to make sure you cut the episclera as well. So conjunctiva and episclera. And then I will open the scissors within the cut, left and right. And you will see a lot of fluid like this, and this one will come out. Sometimes they're what we call loculated. So you may have to do 2 incisions, one medially. And once you've drained it all, you can put a bandage contact lens and you can pad them overnight, or you can do a tarsorrhaphy and then pad them overnight. So I have drained them, especially, as I say, when they come back to see me 5 days, 7 days later, and their eyelids are in the wrong, they're pushed out, they have an ectropion, I will drain them.
So you really release them, you release the fluid.
Yes,
actually,
I mean, yes,
so
absolutely. I mean, you can't leave an eyelid in an ectropion position from chemosis and wait for 6 weeks. It just will cause an eyelid malposition.
Interesting. Right. I should proceed, I think. We have just a few questions remaining. And this goes, yes. A patient calls to report pain, sudden swelling, and decrease of vision the night after blepharoplasty procedure. What should you do? I mean, what should be done? A, advise the patient to use ice pack to decrease the swelling. B, set up an appointment for the patient to see you in the next day. C, make an arrangement to see the patient as soon as possible. D, reassure the patient that discomfort, swelling, and blurry vision are normal post-operative findings. Can we have the poll, please? Okay, so it has been answered very well, and actually by our colleagues here, the audience did very nice, and they want to see the patient as soon as possible. So this is, I should just go. Fine. This is easy one, and it should be complication of upper blepharoplasty include all except dry eyes, scar formation, infection, entropion. Can we have the poll, please? Oh, yes, that has been answered very well, actually. Fine, and I think it's easy so far. Anybody of the audience or the panelists would like to comment on this? We have 2 questions on the dysmorphic body syndrome, and these are tricky somehow. This is psychology. Actually, we need to know the psychology of our patient somehow. And question number 20 say patients with body dysmorphic disorder BDD have type A personality, obvious cosmetic body defect, C, history of multiple surgeries, D, unrealistic expectations. So can we have the poll, please? Oh. Fine. So please, please, anybody could from the panelists could comment on his experience about the body dysmorphic disorder. We are likely to see this every now and then. Who would like to volunteer? Yes.
Dr. Mahmoud, I think in all pre-op consultations, these are
Yes.
very important history taking and
Yes.
getting a good rapport with any patient seeking cosmetic blepharoplasty are important. Type A apex personality, unrealistic expectation. These are all things that we really need to ascertain prior to surgery, because this is where the main issues arise post-operatively. If you missed any of the patient expectations or the outcomes that the patients wanted being greater than what you can achieve. But history of multiple surgeries goes with patients with body dysmorphic disorder, as they've had multiple surgeries in the past, and this could be the underlying cause of their disorder.
Fine, fine. It's not essentially they are type A personality. They could be anything. I consulted my son, who is the psychiatrist. Okay, and obvious cosmetic body defect is not necessary, and history of multiple surgery possibly. Unrealistic expectation, I was doubting whether it works or not. What do you think, Dr. Nareesh? What's your experience with the body dysmorphic syndrome? Dr. Nareesh is around? Nareesh, we lost contact with him. Dr. Farzad?
Dr. Nareesh
Yes,
not here.
Dr. Nareesh, not here. Okay, Dr. Farzad, please. Dr. Farzad is around?
Can you please unmute yourself, Farzad?
Yeah, I can you hear me now?
Yes, we can
Yes.
hear you.
Okay. So Dr. Mahmoud, it's BDD it's really important, and we should understand that about 22.5 to 5% of the general population have BDD. So it's really important to expect that actually 1 out of your 20 patients may have BDD. Why it's important? Because these patients are seriously persuading to do some cosmetic procedures. It's really interesting that more than 80% of patients with BDD are actually going to cosmetic offices to do some operations, some injections, something. But the important thing, they are usually not happy after any kind of the procedure. And as Dr. Nasser beautifully mentioned, these patients usually seek for multiple surgeries. They have lots of photos, lots of actually agents with them to show you how the previous surgeon has did something for them. They usually have mirrors, or they have cell phones to show you the photos, different projections like that. These are the red flags. They are nagging behind the previous surgeons. These are the really red flags that should actually make you suspicious. Maybe some BDD is present in your patient. And it's really important, if you're suspicious to BDD, you need to make sure. I usually consult with actually my psychiatrist consultants to make sure if my patient has BDD. If the patient has BDD, I generally refuse the operation. Why? Because these patients are never happy after any kind of a procedure, even though your procedure is totally true. So it's very important.
Good, very good. So my last question now, it's about the same subject, but it says the management of the body dysmorphic syndrome requires first proper preoperative identification. B, use of special assessment tools and the questionnaires. C, referral to psychologists. And A clear plan for surgery. And can we have the poll, please? خلاص. There are tough questions for the actually for the ophthalmologist. There is a lot of I want to the answer is preoperative. We should really proper preoperative identification. We should know it. This is the answer. Special assessment tools and questionnaire. This is not for ophthalmologists. They do the psychologist or the psychiatrist, and refer to psychologist, not the psychologist. You want to refer to psychiatrist. This is kind of there is difference between psychology and psychiatry. And the clear plan for surgery, of course, there never be the clear plan for surgery. So this is the answer is the proper identification of the condition. Fine. Anybody would like to comment on this? Fine. So if nothing, I would leave you with the very big good luck and thank you for your attention and for your cooperation. I liked your discussion. It was very, very great. I like to, it was maybe lengthy a little bit, but I think it was fruitful. I will thank also Dr. Muhammad Al-Amri, who is the man behind all this. I like working with him so far. إن شاء الله نضلنا هيك على طول. فشكرا دكتور قسيم. Thank you Dr. Farzad. Thank you Narish and Mahdi Fandari. They had to leave because they told me they have a lot of engagement at this hour. Thank you.
Thank you, Dr. Mahmoud. And thanks for all speakers and panelists for this excellent. I was astonished that most of the people, they wait until 2 hours, but it was very nicely prepared. Thank you. Also, I would like to announce for all they are still listening to us that the certificate, CME certificate, it will be given after we finish the last episode. It will be next week in the 9th of June of this module. Maybe after that by 2 weeks or 3 weeks, then it will be ready. Also, we'd like to announce that we already opened the registration for MEOM, 5th MEOM conference, which will be on 19 to 21st of October. With Presbyopia this year, we have the biggest conference of presbyopia in the world for the first time in our area. And also for those they are willing to have or to submit any abstract for any subspecialty, the last day it will be a deadline of 15th of July. So thank you very much for all, and thanks Dr. Mahmoud, Dr. Farzad, Dr. Qasim, and all others. And good night. Thank you very much. Bye bye.
Thank you.
Thank you, Dr. Mahmoud. Thank you, Dr. Muhammad. Thank you very much.
Thank you. Good night. Good night, everybody.
Good night.
Good night, Farzad. Bye bye.
Assalam. Bye
Sure.
bye. See you.
Pleasure.
Thank you. Thank you.
See you soon.
Assalam.